Thank you for joining us this afternoon. I think we'll go ahead and get started. Welcome to the Blue Sky Georgia CTSA group on COVID-19 and health equity. My name is Kathy Grenling. I'm the lead for the collaboration and multidisciplinary team science program of the CTSA. So I just want to give you a little bit of background about what we're going to do today, and then we'll move into some breakout groups. So Blue Sky groups are convened to discuss common research areas and identify potential areas of collaboration. Usually the groups meet once to discuss a broad topic, and then afterwards they might have future meetings, or they might set up a listserv to share ideas. So as we proceed today in this general session, if you have any questions, please write the word question in the chat box and we'll call on you. And then when you're in your smaller groups, you'll be able to unmute and talk. We have three desired outcomes for Blue Sky groups. We hope that you, first of all, meet a potential new collaborator. Second of all, we hope that you meet investigators who have similar interests at other Georgia CTSA institutions. And we hope that you learn something useful for your research program and maybe discover some new resources. So since we have such a big group today, we're going to have a short introduction to the topic by Venkat Narayan, and then we're going to break into 4 breakout groups. When you signed up, you were asked to choose your breakout group. So Lauren will assign you to that breakout group. If you want to switch groups, you'll be able to do that. The 4 groups are the intersection of biological and socioeconomic factors in COVID disparities, the intersection of comorbidities, the impact of COVID-19 on rural communities, and data needs to measure disparities. So most of the discussion today is going to happen in your breakout groups. When we move to the breakout groups, you'll introduce yourselves, and then you'll have about 30 minutes to talk about the burning questions in the field, the best areas for collaboration, and what you as experts in these areas are excited about. So we're going to ask each group to take notes during the discussion and then come and share your big ideas with us starting at about 5 o'clock. So with that, I'm going to turn this over to Venkat Narayan, who's the Ruth and O. Hubert Professor of Global Health and Epidemiology in the Rollins School of Public Health at Emory. He's also a professor of medicine in the School of Medicine at Emory. Venkat?
Thank you, Kathy, and I think thank you very much for putting this together. These Blue Sky groups are extremely useful. I've attended a couple of ones you've done before, and they always result in great outcomes, both short-term and long-term. But I think, so essentially, just to introduce the topic briefly, I want to start off with some very provocative statistics. The US is about 4% of the world population, and we contribute to 25% of the COVID cases worldwide and 25% of COVID deaths worldwide. And it's, in a sense, it's not because of lack of resources, because, you know, when you think in terms of the amount of money we are spending, both in science and technology for COVID and for the healthcare to deal with COVID, we are not poor at all. We're among the highest in the world, even in that area. And yet our outcomes don't seem to be commensurate with what we are putting in. And, you know, one could argue that in terms of biological sciences and technology, the US is clearly at the forefront of many, many things, including COVID research. But yet, you know, for a number of reasons. So one question I want to start off, you know, provoking you all to think about is, why is this? Why is it that a country that is rich, very rich, with strong technological and biological sciences background is unable to manage a pandemic, whereas other countries have managed to do it? Countries like New Zealand, you know, Thailand, many others have managed to do this. Why? That's one policy question I'd like to pose. And I think the answer to this might reside in a beautiful editorial from Lancet. The title of the editorial was, COVID is not a pandemic, it's a syndemic. So where the editor of Lancet took us to was to argue that COVID really represents a watershed of the connection between biology and social determinants. So when you really think of where, who's most vulnerable to developing COVID and its complications, it seems to be people living in communities that are underserved, that are poor, that without healthcare access or without good health policy at the geographical level. And even in the US, the counties most hit are the ones that are vulnerable to some extent. And second, certain populations, whether underserved populations, racial ethnic minorities, like in the US, the populations, getting the worst brunt of COVID are the African Americans, Hispanics, Native Americans, and increasingly, and we mentioned rural communities, the spread of the COVID pandemic now in the US is more and more in the rural areas. So rural communities are also getting affected. So the connection between biology and social determinants, both at the larger geographical policy levels and at the micro level in terms of income, education, discrimination, lack of access, etc., seems to play a tremendous role, both in terms of vulnerability to COVID and also to its complications. And I study diabetes at large. So, COVID has thrown up a number of very important questions in the area of diabetes, and you might be able to identify similar questions in other areas. Firstly, very clearly, even people without diabetes, who, a large proportion of them, when they are infected with COVID, seem to present with high glucose levels. So there have been studies, basic science studies, suggesting that COVID somehow damages or because of its affinity to the ACE receptors, might be affecting the alpha cells and the beta cells of the pancreas. So there is a biological connection there. But then when you think in terms of who with diabetes, people with diabetes suffer the worst COVID complications in terms of hospitalization, admission to ICU, mortality rates, very disproportionately. But who among people with diabetes develop the worst? It's invariably people with socioeconomic disparities, etc. And that's true in England, it's true in the US, it's true in Italy, it's true anywhere. So I think that's one more area. And then clearly COVID, it's not just diabetes, you could think of other comorbidities like hypertension, heart disease, people with strokes, people with other coexisting conditions, older people, are all vulnerable to COVID and its complications. So again, it creates this nexus of biology, social factors, health policy and social policy areas, and the common comorbidities. And what we are learning in COVID is not new, because in a sense, when you look at diabetes across 3,600 counties in the US, there's a difference of 8-fold difference in incidence of diabetes across the counties. And the counties with the highest incidence happen to be the most impoverished communities, communities high unemployment rates, communities with high poverty rates, and community with least healthcare access and access to healthy foods, etc. The same for cardiovascular disease mortality, you find 7 to 10-fold differences across counties. The same for opioid use. And with opioid, there are also connections to policy differences, etc. So there is something happening here that we need to pay attention to. We need to start thinking of a disease or health beyond just biology and technology. We need to bring in the social dimensions, the policy dimensions, the geographical dimensions more carefully, and ask the question, how do we deliver good health? So in terms of the resources available, there are a couple of data and other resources that I'd like to point out to. Firstly, thanks to Shivani Patel, Lance Waller, and many others, we have created what's called a national COVID-19 health equity dashboard. You can go to it, covid19.emory.edu. And this was initially funded by the Woodruff Health Sciences Center, but we have additional funding from Robert Wood Johnson. And what this does is for all the counties in the United States, 3,600 plus, it brings together something like 4,000 variables, county level variables in terms of various socioeconomic factors, county level variables in terms of comorbidities, county level variables in terms of COVID epidemiology, such as incidence, mortality, hospitalization, testing, etc. And it allows very interactive testing, interactive analysis. And for Georgia, this database is being more granularly developed. So this is a great resource, and it's available. It's been covered in Nature, it's been covered in AJC, it's been covered in several other places. So this would be one resource that you want to pay attention to, and it's a number one. And secondly, very recently, as part of the RADIX program, Emory and Georgia Tech has a RADIX testing reference center, where they evaluate the tests for COVID that can be applied to hospital, that can be applied in the communities, and make that information available. And we also got one of the largest disparities initiative undertaken by NIH is around RADIX for disparities. So we had applied for it, and we have a RADIX grant attached to our diabetes center. It's going to allow us to scale up RADIX, the COVID testing for up to 100,000 people in Georgia. And we are creating a panel of about 10,000 people with diabetes or at risk of diabetes who will get tested for COVID. And we are trying to connect the social determinants to the biological determinants to see how you increase uptake for testing. That's a question now, but the same approach can be used for how do you increase uptake for COVID vaccines. So that's going to be the next big question. So I'll stop there. So a lot of interesting questions, and what we learned from COVID may have value beyond COVID. So when we come out of COVID, much of the science infrastructure, the thinking infrastructure that we developed should be applicable to many other things, to diabetes, to cardiovascular disease, stroke, asthma, you name it. So I think I'll stop there.
Thank you, Venkat. Any comments before we move into breakout groups? Go ahead and put the word question in the chat box. While you're thinking, I want to explain how the breakout groups work. Lauren James, who's our administrator here, will put you into the breakout group that you chose in the beginning. Once she puts you in a breakout room, there'll be a little pop-up at the bottom of your screen. It says a breakout room, and you'll be able to use that to enter and leave breakout rooms, provided that you have the most recent version of Zoom. If you don't, and you're in a breakout room and you want to leave and go to a different one, you can leave the breakout room, you'll enter our main room, and Lauren can help you get into the appropriate breakout room. So with that, I will ask Lauren to go ahead and move all of us into breakout rooms, and we'll come back together at 5 o'clock. All right, welcome back, everybody. I hope you had good conversations in your breakout group. And I suspect there may be some intersections between the discussions you had in the 3 different groups. So what we want to do now is just have a general discussion. We'll ask someone from each group to give us the high-level summary of the great ideas that you generated in your group. And then we'll also ask you what you think the next steps are. Is this something where you need to bring more people into the conversation? Do you want to have an actual data sharing session? Do you want to develop a listserv? There are lots of opportunities. So with that, I'm going to ask the data needs group to go first.
No, I'm not muted. So I'm Lance Waller from Biostatistics and Bioinformatics at Emory. So we talked about data. Whenever you have data, you want to know what question you're going to answer. And then there's the data we'd like to get and data we can get, and recognizing there's some compromises there. But some topics of questions of interest were, and some of this is based on experience in the group, some differences in knowledge-seeking behavior. How do people find out whether to wear a mask or not? How do they find out about the vaccine? How do they find out about other things? Some comparisons of parental division of labor and staying at home. So these aren't necessarily disparities about COVID itself, but disparities about the impact of COVID on standard lifestyle and other healthcare. But some interests like participating in donating blood, dialysis, your routine healthcare that you may not have access to or be comfortable doing. how does that play out in different subpopulations? We've talked about some geographic mapping, which is an interest area of mine. I wasn't the only one who brought it up, but it is interesting to me. And some of the GPS tracking and mobility and commuting patterns that may have changed people that still needed to go out versus people who could work at home. Contact tracing. That led to some discussion about older adults and their activities, which ones are going to, say, church or community things or events. Are they stuck at home or in where they live? How is their mindset and app development, diary aspects of those? And then we have a couple of healthcare, health policy researchers in our group. So we talked a lot about claims data, which we use in standard analysis, but the sort of speed of COVID research, do it now, do it now, do it now, doesn't lend itself to claims data that may not be available for 6 months or some period of time. And we shouldn't throw that knowing what to do with that away in lieu of something that seems close but not quite. So we want to maintain the discussion of how our claims are filed. Some aspects that may play into other disparities are uptake of telehealth, use of telehealth for routine care. How do the claims data change? And then also some of the billing practices in healthcare system. Some anecdotes and stories of added costs or hidden costs, a test that's free, but your office visit is not free, or you came in for the office visit and we're going to pad the claim with a few other things like a flu shot and some other things that you really didn't get, but we need to make up for some of the lost visit. Not that anyone on this call would do anything like that, but there's some level of claims fraud that occurs in healthcare. And is that different now? And is it different for different patient populations, different small clinics versus large individuals? So really a lot of interesting equity things orbiting because of the COVID impact that maybe aren't the inequity of COVID itself, which is interesting by itself. So we mentioned several of those things, and then we spent some time talking about data we might be able to get on both flu shot uptake and then the vaccine distribution and rollout, or vaccines, multiple vaccines. So the recommendations, but how does this play out? How comfortable are people getting the first round of vaccines? How does that differ by different groups? So a lot of our data came back to the health services claims and filing, that type of information. What will we be able to find out for that? But noting that that's working at a time delay that's very different from kind of the last week's preprint is old news view of research. So that's a quick summary of where our conversation was going. Some of it's driven by our own personal interests, and some of it was our experience. But I was interested in the healthcare data in addition to, say, the electronic medical record and so on, that the claims data we were talking about.
So before I ask you about next steps, anybody from one of the other groups have any reaction or something they'd like to add to that? Because it sounds like there's lots of interesting questions to be answered. Go ahead. You don't have to unmute yourself, so just go ahead. And you don't have to. Just go ahead and unmute yourself if you want to say something.
Lance, I was wondering if your group is familiar with the data that Georgia Tech and Emory is publishing on COVID as we're collecting it. That's my first question, and my second comment is as far as the claims data stuff. We actually are going to start putting together an all-payer claims database for the state of Georgia. That's going to be a little while. But we're going to start that, I think, in January, building that. So if that's an area that's particularly interesting to you as we put together our board and our advisory team and everything, let me know.
Yeah, that would be really helpful. Can you say a little bit about the data that's currently being put together that you mentioned first?
Sure. So I think somebody posted earlier the COVID-19 the one from Emory, and at Georgia Tech we have all sorts of data from all over the state and everything. So maybe Victoria, if you have it handy, if you could send to the group where to pull that information. So we'll get you that link anyway. Maybe it'll help with some of your interests.
Yeah, that would be great. Yeah, thanks very much. One type of data we were talking about and having trouble getting consolidated anywhere were the test site locations. There's some information that covers a lot of it, but it's hard to find all of it in any one place. So I don't know if that's something that's in your collection or not.
So test site locations is in just kind of the general Department of Public Health data or specific?
All of it was what we were trying to find. You know, there's Walgreens and there's the open this week, but not next week. And there's the charitable organizations that come in and set up and.
Mm-hmm. Well, I think, I don't know if anybody else on the call has looked at the data that they published from the Department of Public Health. But basically everything has to be reported to them. So that's sort of the central repository. So a lot of the stuff that we have posted at the Georgia Tech website is based on a collaboration with the Department of Public Health to pull that information.
Okay, great, thanks. Any other comments from others? That's really helpful information, Megan, thanks.
Can I ask Megan about the all-payer claims database? Is that a Georgia thing that's coming through the legislature, or is it a tech thing that you guys are starting?
The Georgia bill has already passed, and we at GTRI are going to be setting up the all-payer claims database. So we're all the components of it. We're the administrators for it. So that starts early next year. Well, sort of starting now, but yes, it will be for the entire state of Georgia.
So I think you have a bunch of people on this call that would probably be interested in that. So take note of who's speaking. That we may inundate you with email. There's Victoria just posted the Georgia Tech test surveillance website. Any other comments for Lance before we move on? Did your group decide what the next steps would be, or you want to just having today's conversation was enough?
Well, I think today's conversation was a good thing to get started. There were a couple of follow-ups between pairs of people on our call. And I think we got most interested in talking about these questions available, and it's good to share that with the group here. If any of these resonate with you, let us know. I think we'd like to follow up. We didn't pick a particular topic to follow up on, so it may be a subset of people want to dig into some of these.
So if you do, if there's a subset of you who want to interact and you need help setting up meetings, Lauren James, who's the peach on our little grid here, she's actually a person, there she is, will be happy to help you. All right, let's move on to the impact of COVID-19 on rural communities, Henry, or whoever the spokesperson for that group is.
Megan is going to be our spokesperson.
Big shock. Jesse, you're laughing too hard. Okay, so we had an interesting group actually from multiple organizations and countries actually. We had someone with us from Ghana, Ms. Marina. It was wonderful to have her perspective as well. So we talked about the burning issues regarding COVID and health equity, both in the US and a little bit in Ghana. But it really kind of comes down to access to technology, access to care, both testing and care once if they are sick. It's education, what are people being told about COVID, and how does that instill kind of implicit biases within the cultures. So in talking to Marina and what can we learn from what they did in Ghana, and her response was that they actually listened and used PPE and did all that stuff. Some of the challenges are also mental health challenges. That's one of the big ones, of course, and the social isolation the stigma that's associated with mental health that tends to be more prevalent in specific communities. Another big one is kind of the faith-based communities, and people are struggling with that. What's our new norm for celebrating ceremonies, for worshiping, for funerals? How do we help people figure that out and feel good about it, feel comfortable with it, and still feel like they're able to worship in the way that they need to? I think that's most of that. Also just kind of the general support for having kids that are home from school all day, and for people who have to work, for people who rely on school systems for food, for access to food and nutrition. These are all big issues for the rural population. And then some things that we talked about for how we can work together is sorry, my dog is whining. If you can hear her in the background, I think it's time to go to the bathroom. So one of the things we talked about is really the importance of connecting communities and technologies, as well as needs and preferences. So that's one of the things that came up on our call, was that we had people who have access to the people who need this, and then there are those of us who are already working on the technology, and we combine that together, and it's sort of making the best of it. We talked about the challenges with delivering supplies to rural areas, and we have a lot to learn from Ghana with using drones to deliver medical supplies, and the success of that program. It's how do we get the tests to the communities and bring them back, and the need to find some that don't require things like refrigeration on either end, so that they can be tested and have the results quickly. Refrigeration is a big one. And then also leveraging the use of technology and mobile health monitoring that's going to be critical to managing care in rural populations. So those are some of the things that we're all interested in as well. Did I capture everything?
So I just want to mention that we have another Blue Sky group on drones and rural health.
That's what Henry said.
And they are talking about, what are the best uses of drones? And they've done a survey with some of the rural communities to see how well that would be accepted by folks who live in a rural and might be a little nervous about having a drone land in the front yard. So maybe we'll connect those two Blue Sky groups.
Yeah, well, Ghana has a model for us to look at, and how they implemented it successfully is really an amazing thing.
We may invite you, Marina, then to that other group to give them some insight into how it works. Other thoughts, reactions, or next steps for this group?
I think Megan forgot to mention something about food insecurity, possibly getting worse during this pandemic due to lack of access to imported food. For instance, Ghana relies heavily on food importation. And so with the lockdown and with the closure of most borders, we didn't have food coming in or going out. And so food insecurity is likely to really go up during this pandemic, especially with families also getting sick and other people losing their family members. And that is one thing that we forgot to mention from our group.
Thank you.
Any other reactions or suggestions? Sounds like you made some connections that you needed to make between technology and those who have access to the rural populations. Are there other ways that need to be followed up, other things that need to be followed up on?
I don't think so, unless there's anything that anyone on this group heard us talk about that either you're already working on or you know people who are working on those that we might want to connect with.
I would just add that I know you said about schools getting food out to, because, you know, to the rural areas. And I know the person that I work with that works on school-based programming, I know that the schools in the rural areas that have the lowest income populations and the most need are the ones that couldn't get the food out to the kids. So I know that I'm sure the state would be interested in any solutions that people have around getting the free and reduced school lunches out to those rural areas. They also couldn't make it happen with the amount of money that they had to make, you know, individual boxed lunches or whatever is more expensive than serving, you know, group. And so that was also part of the problem, that in rural areas, you need more to do individual level delivery of food. So I don't know if they've solved that problem, but I know it was the poorest areas that were the most impacted, and the inability to get them their food.
It's good to know. Well, not good to know, but it's important to know. Let's have the last group report out. That's the intersection of biological and socioeconomic factors. Who is reporting for that group?
This is Jesse. I can at least start and see if folks have other comments. So we had a great conversation. We had a very diverse group. We had folks who were engineers, surgeons, immunologists, cardiologists, and more. And so had a lot of different perspectives. I think the major part of the initial part of the conversation was, you know, how do we make an impact? And I think the couple of talking points. So one was you know, trying to define different levels of engagement and trying to quantify these. So one level of engagement is at the level of the community. So how do we get, so in some of these disproportionately affected populations, how do we get them to get tested, for example? So one of the members in our group noticed that, you know, hey, we set up these testing areas, but the Latinx population wasn't coming. And so what's driving that? And part of that may be that, you know, they're more likely to live in a multi-generational home where if one person gets sick, it doesn't just impact them, it affects all the people they live with and they potentially work with. And so trying to understand what some of these socioeconomic realities are and the way that they may affect people's outcomes. One thing that came out from that is one question that came up, and maybe Lance or other folks on the call who are familiar with the data know, but you know, there's, you know, obviously all kinds of data at the census tract level on poverty and all these other kinds of things, but are there things that quantify things like how many people live, how many people are in a household, how many people work together, and those kinds of things that may not be easy to measure, but may really kind of impact behavior and outcome, and are related to, you know, ethnicity, for example. So that was kind of one thing that we talked about. I think one great comment from the group was that, you know, race is not modifiable, and what if it's place and not race? And how do we disentangle this in sort of when we're trying to do these analyses, where, you know, the typical kind of thing to throw into a model is, you know, age, race, sex, but race isn't modifiable. And so if your finding is that, well, Black race is associated with worse outcomes, people go, well, yeah, you know, we can't fix that, so we just got to be on the lookout for it, but it's not really actionable. And so should we be, what kinds of data would we need, or what could we use instead of or in addition to race that would then be modifiable? Things like income level, access to care, or other things that we could look at that could potentially be amenable to policy modifications, so that we could actually change things instead of just saying that, you know, it is what it is. Kind of related to that, you know, the other thing that we kind of talked about is that for a lot of our patients, we don't capture our data very well. So even among healthcare workers or our patients, when we're pulling race and ethnicity, it's often either incomplete or not accurate. And so we're sort of working off data that's hard. And I think a lot of times people either decline to answer. I know personally I've had some data that I've gotten where it turned out that they didn't ask, they filled in the race for somebody. And so, there's lots of issues with, how do you actually act, if you're looking at disparities in race, for example, how do you make sure that you actually have accurate data? How do you count? But I think there's a sort of the sense that, this is sort of that COVID is highlighted a lot of these inequalities. There's a lot of these biological variables that we know are issues or that we think are potentially issues. And this is the time when the awareness is high and we can actually, we actually have the opportunity to actually do something with it. I think one of the things that we struggled with was, what data can we get and how can we best use it?
Sounds like you need to talk to the data group.
Yep.
Reactions or answers to some of those questions?
So I think there's a lot of data available at the neighborhood level. It might not be exactly what you want, which is sort of the nature of this. There's the data you want and data you can get, and you try to get them as close together as you can. One of the things that came up in the data group that we discussed too is some of the neighborhood information in any city, including Atlanta, is an echo of a lot of policies and things from the past. So redlining and segregation, there's still echoes of where people buy houses, and even if they're not legally restricted from it, you live in a house for a long time or in a neighborhood for a long time. So the social determinants of health, linking some of the interest in this with some of the disparities researcher and social determinant of health perspective might be really helpful, because there'll be certain census data that are often used to give you some comparison to other areas, but there's also that insight in that it's not quite what we want, neighborhood cohesion or collective efficacy kind of measures aren't things that are directly from the census, but we try to measure them somehow. So anyone who's interested in following up on discussions on that, it would be great to connect some of the dots there too.
And Lance, thank you for those comments. That's Anish. I think I might have been one of those that brought up this problem. We've been working, or a project led by Rachel Patzer and Xanthia Wiley, and I don't know which group Xanthia was in, but what we found is there was so much missingness of data that linked to social determinants of healthcare, including race, gender. I mean, frankly, wrong in our medical record systems. People that identify themselves as male are recorded as female. People who identify themselves as African American don't have any race and just are non-Hispanic. And let alone completely wrong addresses, zip codes. So it really makes a true investigation into these social determinants of health, and where in our group we were talking about where is the biologic determinants and where are the socioeconomic determinants and where do they meet. It's really impossible to do good work without good data in the first place. And I think there's not a lot of incentive until recently for our healthcare systems to record these data accurately. And we need to build upon this to make sure there's a sustainable quality data entry in our healthcare systems for these social determinants.
Yeah, thanks, Anish. I think that's an important point. And it also speaks to the need for, or importance of collaborations between people. Sometimes you'll say, oh, there should be some neighborhood information about this. And then you have exactly the experience you talked about. You dig in and there's missing stuff and it's not quite right. And if you collaborate with someone who's that's their kind of area of interest, they've sort of sweated through some of this and they know what some other people in other places have tried to do. So sometimes we tend to think because it exists, it should be easy to use. And I think the real power and the best work kind of comes from these collaborations where the people who are familiar with the data get together with the people who are familiar with healthcare A lot of the zip code work, zip codes in our record for billing, and as long as the bill gets paid, it's good enough data, but it's not, it doesn't connect some of the other uses we'd like for it. So
that was exactly the answer I got when I asked this of the healthcare system. The bills went through.
Yeah, exactly. So it's accurate, but you think about college students and where their parents live and so on. So I think a good spin out of this would be some groups who worked in different pieces of the puzzle here and bring us all together around some of these issues. So thanks for pointing that out.
So Jesse, any obvious next steps for you guys? It really sounds like maybe there needs to be some more discussion across these two breakout groups. So we can either reconvene another one, or we can do this by email with a listserv, or if you heard something, we could just leave it up to you as individuals to connect with people that you thought were interesting that you heard from today.
Hey, I just want to put in, I guess, another thought behind some of the data gaps. So I think that recognizing what data we need is important, but I don't think that that's sufficient to actually get people to choose to share that data. I can tell you, I personally am always questioning, should I put my religion on this form? Should I put my gender on this form? I can only imagine how much stronger that feeling might be with some other groups. And so I think that something really important to do would be to work with community groups who already have some level of trust, and really work with them to try to understand perhaps people's reticence to share some of those. And also, if you want to create an education campaign that helps people feel safe sharing some of that data, you really need to work with organizations who have trust and work through those community-based organizations.
Henry, she's speaking your language. Henry has those sorts of connections with some rural Georgia.
She is, and in fact, it touches upon so many different things. We are going back to the data issue and the missingness of those data that link to social determinants of health. Going back and reviewing hospital records down in Southwest Georgia. We're constantly being confronted with that issue, and then validating, making sure that folks' characteristics are what they say they are in the data. But then also, speaking with one of the things that I would love for us to do is connect our group with community folks. In our group, we immediately started talking about testing. And it perked my interest because just Friday I was talking with a group that says, "Hey, Doc, can you help us get some testing? We need some testing." They said we just lost 4 members in our church. Can we do something? So there's a lot of need, and I'm looking at Anish. Anish spoke in one of our Zoom events, trying to provide a little bit better education around COVID and safe practices. Some of our community members had interest in, how do we go back to church? So we, put together a group and provided some good information on those topics. So we just need to figure out, how do we connect the expertise that's in this group with those community needs.
Henry, I just thanks for talking about that wonderful event that you invited me to. But I think one of the things that you have brought up, and I think is really important, and we're at a good opportunity now to try to figure this out, is faith-based groups and community groups have a long tradition of being involved in the healthcare of those that live in those communities. And I think we have over time moved a little bit away from that. And I think this is a really good opportunity to rebuild those connections between not only healthcare, but public health and our community-based or faith-based groups, and try to rebuild those links.
Well, I want to thank everybody, because we're out out of time here. I think maybe the best way to continue this conversation is if you have questions or ideas that you would like to pose to the entire group, we'll take the 20 or so people who stuck with us the whole time. Send those to Lauren James, and she can send them out to the whole group, and we can see if there's another smaller group that would like to reconvene to consider some of these ideas.
I just have a quick comment, if you don't mind.
Sure.
Question. Does anyone have what's called a community advisory board? Because that's what we work with, and they have those that are actually in the community to handle some of these things. So, but again, we can talk offline with that, but that's worked well at Morehouse School of Medicine.
Mm-hmm.
We do. We have an advisory group, and this is with integrating special populations function within the Georgia CTSA for one of our projects. And, that group helped us, put together this program that, Anish was just referring to.
Okay. All right. Yeah, I want to be respectful of everybody's time, so we'll end for today, but thank you for coming. I hope you had great conversations. I hope you all met somebody you'd like to continue to collaborate with, and let us know what we can do to help. Thanks very much.